Thank you to everyone for joining us today. For those of you who are joining us for the first time, iCourts is a community of practice whose goal is to connect people who work in the social and behavioral sciences field of neglected tropical diseases. Once a month, iCourts hosts a Knowledge Café webinar where we provide the opportunity for community members to present on a topic of their choice to a global and virtual audience. If you have any ideas for a Knowledge Cafe, please reach out to us at info.icords@gmail.com. And if you'd like to join as an iCords member to stay up to date on our activities and events, click the link in the chat to fill out the Google form or scan the QR code on the bottom right side of the screen. This webinar was developed in collaboration with Glide. Today, we have two speakers, Dr. Adam Craig and Dr. Ajib Diptianusa, preceded by a short speech by Dr. Ngozi Arundu, Technical Director at Glide. During the session, please feel free to introduce yourself and type in any questions or comments you have using the chat, and we will address them in the discussion portion of the session. Please note that this session is being recorded, so please keep an eye on your microphone and make sure that it is muted until the Q&A period. At the end of the webinar, we have a few exciting announcements, so please stay till the end to hear about our upcoming activities. Our session moderator is Naufal, who is a senior advisor at Glide. I will now pass it over to Naufal to introduce the session and our speakers.
Thank you. Thank you very much, Farsa. Good morning, good afternoon, and good evening from Abu Dhabi to friends and colleagues joining us from different regions around the world. On behalf of iCourts and Glide, it is my pleasure to welcome all of you today in this Knowledge Cafe on sustaining elimination through integration. And today we will hear experience from Pacific lessons for NTD programs. Today's discussion comes at very critical moment because many countries now are transitioning from NTD's control to near and post-elimination stage, where sustainability becomes increasingly critical. And also this will be in line with the mandate in 2030 Global NTD's roadmap. We are very fortunate to have two distinguished speakers today who will share the practical experience from Indonesia and Niue, two different countries, two different contexts, but I believe both of them can offer valuable lessons on sustaining elimination gains. To officially open today's session, it is now my great honor to invite Dr. Ngozi Arundu, Technical Director at the Global Institute for Disease Elimination. Dr. Ngozi has been a strong advocate for integrated and sustainable approach to disease elimination, and we are very grateful for her support for today's discussion. So Dr. Ngozi, without any further ado, the screen is yours now.
Thank you so much, Nofal, and good afternoon, good morning, good evening to everyone. It is my pleasure to give a few opening remarks on behalf of our CEO here at the Global Institute of Disease Elimination. It's with great pleasure that I welcome you to this Knowledge Cafe, which is jointly convened by Glide and iCords on the topic that is both timely and critical, as Nofal said, which is sustaining disease elimination through integrations through integration lessons learned from the Pacific region. Over the past decade, we have witnessed significant progress in the fight against neglected tropical diseases. Many countries now are approaching elimination or they've already achieved key milestones. As of March 2026, 61 countries have eliminated at least one NTD, and the number of people requiring NTD interventions has declined by 36%. However, as we move into what is often referred to as the last mile, the nature of the challenge fundamentally changes. Success brings new complexity. As disease prevalence declines, traditional vertical programs gradually become resource intensive, less efficient, and harder to sustain. At the same time, political attention and financing may shift elsewhere. This creates a paradox. The closer we get to elimination, the greater the risk of losing momentum. And this is precisely why integration is no longer optional, it is essential. I believe countries in the Pacific region provide compelling examples of how integration can be effectively operationalized and really help us to overcome this challenge. At Glide, integration really sits at the core of our work. not only as a technical approach, but also as a strategic pathway to sustain impact, strengthen resilience, and future-proof elimination gains. Allow me to briefly highlight two areas where we are advancing this agenda. First, through our Falcon Awards for disease elimination, which some of you may have heard of. Through this, this is a grant vehicle, basically. We are able to support locally led innovations that demonstrate how integration can be operationalized in real-world settings. In the Western Pacific region, we had a Falcon Award that was fully dedicated to the region in 2024, and we supported projects that showed countries how to integrate surveillance across diseases and platforms, leverage environmental and climate data, and strengthen preparedness and response, as well as embed some of those lessons and those approaches into community-centered approaches and program delivery. In this webinar, you will hear a country example from Niue, which was one of our Falcon Award winners, where NTD surveillance was integrated into non-communicable disease surveys. Now, the second way that GLIDE is really uplifting and supporting this integration agenda is by increasingly investing in data innovation as a key enabler for integration. In near and post-elimination settings, the ability to detect signals early, whether through integrated surveillance platforms, geospatial modeling, or AI-enabled diagnostics, is really critical to preventing recrudescence. And we're working closely with partners to strengthen the interoperability of health information systems and promote the use of geospatial and predictive analytics for more targeted interventions. This really requires exploring AI-enabled tools and enhancing diagnostics for decision-making. I think I'll leave those two examples with you, and just kind of to sum up, today's Knowledge Cafe brings together practical experiences from Indonesia and Niue, two very different contexts, yet both demonstrating how integration can be translated from concept to action. I hope this session will not only showcase these lessons, but also stimulate honest discussion on what it takes to institutionalize integration beyond pilots, beyond projects, into national systems. Let me close by emphasizing that elimination is not the end of the journey. It is the beginning of a new phase, one that requires resilience, adaptability, and partnership. And at GLIDE, we remain committed to working with countries and partners such as ICORDS to advance integrated discussion. Over to you, Naufal.
Thank you. Thank you very much, Dr. Ngozi, for those inspiring opening reflections and really setting up the stage today. Now, our first case study brings us to Indonesia, my home country, where integrated program review approach have contributed not only to identify systemic bottlenecks in the country, but also to catalyze high-level policy reform. Now it is my pleasure to invite Dr. Ajib Diptianusa from WHO Country Office Indonesia. Dr. Ajib will share experience from Indonesia on integrated skin NTD program review that has been conducted a few years back, and how technical findings help inform multisectoral engagement and contributed to high-level policy uptake in the country. Over to you, Dr. Ajib.
Yes, thank you, Naufal, for the introduction. So, hello, colleagues from various parts of the world. Good morning, good afternoon, good evening. Thank you very much, ICORDS, and also GLIDE for the invitation. And today I'll share Indonesia's experience on the integrated scheme NTD program review and how the findings are now contributing to broader policy reform discussions for NTD control in Indonesia. And this presentation mainly focuses on leprosy, yaws, and also lymphatic filariasis. And please, next slide. So I will briefly cover 4 areas today. First is why Indonesia decided to conduct an integrated review for skin entities at this stage of elimination. And then second, how the program review was conducted across different districts and stakeholders. Third, the major bottlenecks identified from the review. And finally, how these findings are now being translated into broader policy reform and discussions toward a binding policy at the national level for NTD control. Next slide, please. So this slide shows the substantial progress of Indonesia towards disease elimination. So basically for LF, the population requiring preventive chemotherapy has decreased by around 98% from the baseline in 2014 to only around 1 million in 2024. And there's only 26 districts continue to show ongoing LF transmission requiring MDA. So it's basically around 10% of the total of endemic districts of LF. On top of that, yours prevalence has also declined substantially to only 0.27 in 100,000 population. However, we still reported nearly 15,000 new leprosy cases nationally back in 2024. And these figures show that Indonesia is near the last mile, but not beyond the risk of these diseases. So what we observe is that persistent transmission is increasingly concentrated in remote, undeserved, and operationally challenging settings, especially in those difficult terrains and geographical boundaries. And at the same time, our practice of decentralization has created fragmentation across surveillance systems, financing, reporting, and also logistics. In some places, as the disease burden declines, maintaining these programs alone become more and more difficult, both financially and also operationally. And therefore, in 2024, the WHO, along with the Ministry of Health and other partners, have conducted an integrated program review for skin entities that was aligned with the WHO skin entity framework, not only to improve programs, but also to generate evidence for the longer term policy reform. You can go on to the next slide, please. Yes, so as most of you might have been aware that Indonesia is an archipelago, so the review focused only on 3 districts representing different operational realities along with different challenges in disease control and elimination efforts. So the first district is Belitung district, where this district had already achieved subnational LF elimination certification back in 2016. But later investigations in around 2020, 2021 identified zoonotic transmission of Brugia malai in the district. And the second district is the Sorong Selatan district, which is a remote district in the Papua region with high leprosy burden, remote indigenous settings with many geographical inaccessibility, cultural barriers, and also heavy dependence on outreach in terms of health services. And the third district is Mimika district, also located in Papua region, selected for its urban and peri-urban complexities, along with the private sector complexities in the district, high population mobility, and also security constraints. And these districts demonstrate the different challenges and are highly context specific. And the challenges are no longer only biomedical, but increasingly involve governance, logistics, geography, social trust, and also sustainability of the program itself. Go to the next slide, please. So then the Skin Entities Program Review conducted in 2024 used a mixed method approach. So first, we analyzed routine program indicators, laboratory records, treatment registers, and also surveillance reports, combined with structural observations and also thematic analysis, according to the WHO Skin Entities framework. And importantly, we involved stakeholders from multiple levels, which included primary healthcare centers, district health offices, laboratories, clinicians, and also other health professionals, program managers, communities, and also external partners into the review. And the analysis was intentionally organized around system components such as governance, financing, surveillance, workforce, and laboratory capacities, rather than analyzing these diseases separately. So we took the analysis into the broader term covering these 3 diseases. And this is important because many of the bottlenecks tend out to be shared across these diseases. Can you go to the next slide, please? So from the review, we have identified key bottlenecks, this major bottlenecks. The first one will be geographic access, because in some districts, reaching health centers may require 6 even to 12 hours of travel, and sometimes with additional security concerns. And the second major bottleneck is governance and financing, because in decentralized settings, scheme entities often lose budget priority to larger programs such as TB, HIV, and those programs in maternal and child health, like stunting prevention and so on and so forth. And the third bottleneck is workforce capacity, of course, because we identified only around 90% of health workers in the reviewed facilities has never received formal trainings on skin entities. And we have also identified limited referral capacities in major hospitals in the district. And even we found that even like leprosy cases were referred to internal medicine instead of dermatologists. And the fourth bottleneck is about data and logistics, because many reporting systems remain paper-based with delayed treatment initiation and weak referral systems and inconsistent supply chains, as we also identified frequent stockouts of disease logistics during the review. And finally, the last bottleneck is stigma and mistrust. In some areas, communities became more hesitant toward mass drug administration activities after COVID-19 experiences, especially towards the health workers. While on top of that, stigma has also affected contact screening and also chemoprophylaxis uptake in some areas. And overall, these findings show that remaining barriers are increasingly more systemic rather than purely disease-specific barriers. Can you go on to the next slide, please? Thank you. So I would like to emphasize the particular case that we observed in the Belitung district. As I mentioned previously, that this district had already passed the transmission assessment surveys and had achieved a subnational elimination certification by the Ministry of Health. The later investigations detected infections in animal reservoirs and also in humans, and this shows that human-only surveillance may not always be sufficient, especially in the settings of the zoonotic transmission risks, such as in Belitung district. And therefore, post-elimination surveillance must evolve towards One Health approaches that would include animal health components, and that will also include vector-related components, not only human component in the surveillance systems. And the review also highlighted the need for interoperable reporting systems and also stronger integration among health facilities like hospitals, laboratories, primary health centers, and also community platforms in both detection and also treatment and referring their patients. And this is particularly relevant to the current Knowledge Café theme, because integration is not only about efficiency, it is also about resilience against rebound or recrudescence after elimination milestones are already reached. Go to the next slide, please. So this slide shows how this technical review translates into the development of policy, as this is important, I would say, politically, because the review itself serves as an evidence generation and the findings are now being used as advocacy tools to elevate scheme entities elimination within national and also subnational planning discussions. So we are on the move on this development of finding policies at the national level. And this is also important, well, as I mentioned just now, strategic advocacy. The evidence will support discussions toward the development of the policies on anti-diss control. And we, from the gaps that we have identified from the review, we have showed the barriers, the challenges from the program that involved multi-sectoral governance coordination, as well as district accountability, which cannot be solved by vertical programs only, just for example, from the Ministry of Health alone. So we need coordination from multi-sectoral and also cross ministries. And this would lead us to the institutionalization. So we are hopefully developing this as the presidential regulation that will help in institutionalizing the national targets and also roadmaps and coordination mechanisms, harmonized systems or integration into long-term planning, and also sustainable financing for post-elimination surveillance. So the transition itself from the technical review to policy reform is essentially moving from identifying the technical or operational bottlenecks toward sustainable solutions for the future. So can we go to the next slide, please? So to conclude, I would like to leave 4 key messages. So the first one will be last mile elimination is increasingly a systems challenge rather than a disease-specific challenge. And second, integrated surveillance can improve efficiency, equity, and sustainability, especially in resource-limited settings. Third, policy reform must be accompanied by operational adaptation at district level. And finally, Indonesia's experience highlight the importance of context-specific integration and also One Health approaches for sustaining elimination gains. Go on to the next slide, please. So I'd like to acknowledge the Ministry of Health of Indonesia, WHO colleagues, technical partners, universities, and all district teams and communities involved in the program review. Next. Thank you very much for your attention. I look forward to the discussion.
Thank you. Thank you very much, Dr. Ajib, for this insightful presentation. I think from the presentation, one important takeaway is how program review process in the country can serve not only as technical exercise, but also as a strategic advocacy tools for policy and system strengthening. Let's move to our second presentation. Now we shift toward operational integration and surveillance system from the Pacific Island context. It is my pleasure now to invite Dr. Adam Craig from the University of Queensland. Dr. Adam will present the experience from Niue on integrating LF post-validation surveillance with WHO steps for non-communicable diseases risk factor surveillance. But before handing over to Dr. Adam, I would like to encourage all of you to continue submitting questions through the chat box function in this Zoom. And now, Dr. Adam, the screen is yours.
Dr. Adam, you
I'm
are
sorry.
muted.
Yeah,
That would help. Is that better? Yeah. Thanks, Nigel, for the introduction. And as Ngozi mentioned in her introduction, the study that was conducted, or this work that was conducted in Niue, was the result of a Falcon Award, one of the Global Institute for Disease Elimination's Falcon Awards from 2000 and 2 years ago now, so 2024. My name's Adam Craig. I work at the University of Queensland in Brisbane, Australia, on the East Coast. This is our beautiful campus, and Brisbane in the background there. We, as a university, have a program called the Operational Research and Decision Support Program for Infectious Diseases, and a large part of that program is around work on neglected tropical diseases, largely in the Pacific Islands. And in particular, my area and Dr. Harry Lawford, who's also on Line's area, is looking at post-validation surveillance in that context, which is what I'll be talking about today. We also host an annual meeting on LF elimination and surveillance that has been happening for the last few years, and it's planned at the end of the year. So those that are interested, please reach out. We can talk about what's happening this year. I just wanted to show this map to start with. So when we talk about the Pacific, it's a collective of 22 countries. But when you look at all the little tiny dots, some of those countries have thousands and thousands of islands and atolls, many of which are inhabited. So in a way, it's lots of little nations all together. That combined with very limited resources, and when I'm talking small, I'm talking ministries of health of 8 or 9 people working in public health. The challenges in delivering surveillance for a neglected disease are exponentially more than you would experience in other settings. I had a colleague who worked in Ebola areas in Africa, and he came to the Pacific, and his comment was that working in the Pacific is 3 times harder than anywhere he'd worked ever before, just because there's no roads and there's no people and there's no laboratories. So when we're talking about delivery of NTD services in these contexts, integration is a no-brainer. So the work we're doing in Niue, and Niue, if my mouse works here on the screen, is just around Samoa there. I'll get to it in a second. It's a little tiny island near Tonga and Samoa. It's got a population of only, on paper, about 1,500, but in reality, about 1,300 people who live on island at any one time. It's wrong one. It's a country that's in free association with New Zealand, which means that while it is a member of the UN, of the WHO, it's not of the UN, and it's not an independent country. It relies on New Zealand for things like finance, foreign affairs, and other services. So it's got this special relationship with New Zealand. It's also one of the most isolated and remote countries in the world. There's only 1 flight a week into and out of Niue. So if you can sort of contextualize what that's like, it's very opposite. It's almost the complete opposite to what Ajib was talking about in Indonesia, where you're talking about millions of people. The photos on the right-hand side there, obviously a sufferer of LF, the worms, and a photo on the bottom there from Kiribati, which is another Pacific Island country, just to highlight that LF is really a disease in part of poverty. And in countries in the Pacific, extreme levels of deprivation and lack of access to care. So in the Pacific, LF's been around since hundreds and hundreds of years. The first documentation of the disease was actually in Captain Cook, the British explorer's diaries. So back in 1786 was first documented, and at one point there was all 22 countries had evidence of LF transmission. At the beginning of the global program, so in 2000, there was 16 countries in the Pacific, and these are the ones with the dots around them on the screen. But with all the efforts through the global program, half of those countries, so 8 of those countries, were validated as having eliminated the disease. And there are the years that those countries were eliminated. If you don't know the Pacific, you can sort of do a quick cross-reference for where they are. In the brackets after each of the country names is when, if so, when a PVS study was done and how extensive that was in broad terms. So Niue, we're currently doing that study at the moment. I just got back 2 days ago from a survey there, and that's only on 3 of the islands, and there's something like 15 islands in the country. So it's just a very, very small sample. Niue we're talking about today, and then the others there. just noting some of the countries are well over 10 years or approaching 10 years and haven't had any post-validation surveillance. So we really don't know what's happening. And then other countries that we've been working in, Tonga, for instance, who have reached elimination, are now finding that they've got quite large pockets of transmission happening. Same in Wallis and Futuna. So to Niue. So it's a small country. As I said, it's in the middle of the ocean, basically as far away from anywhere as you can get, and has a small population. But it is actually a real leader in elimination of disease, both lymphatic filariasis, but also it's probably the first country to eliminate measles and mumps and hepatitis too. So, or viral hepatitis. So it's doing well, but that's partly because of its geography and its location. It's called the Rock of Polynesia, and it looks like this, and it's beautiful. Absolutely beautiful country. A rock that sits 30 meters above the sea level, and you climb down little ladders to get to these beautiful beaches. And the people, it's lovely, it's gorgeous. Well worth the trip if you can ever get there. The study that we did with Glide and the Falcon on board was this post-validation survey to determine whether or not Niue, 9 years after elimination, had maintained that status. But at the same time, to do integration, to use the opportunity to integrate to use the opportunity to also collect dry blood spots and do multiplex bead assays on a panel of other priority diseases. And importantly for the GLIDE program, but also the Pacific more broadly, to use Niue as a case study to build evidence or local evidence to support this concept of integration for NTD surveillance and control. So to generate local evidence. Just briefly, the vertical lines there, the dotted lines are the different MDA rounds, and the dots are different surveys over time. You can see that Niue, a small population, while remote and while under-resourced, has been very well serviced over time. And that's partly because of its link with New Zealand. So back in the first surveys in the 50s, prevalence rate of about 23%, and that's got right down to just a few cases in different surveys. So in terms of integration, we integrated our survey with the with the World Health Organization's non-communicable disease risk factor survey. So this is a big, if people don't know what the STEP survey is, it's a large national census. In Niue it was a census, in other places it's a sample, which looks at risk factors for NCD. So everything from your diet to your smoking and other risk factors. An interview that takes about an hour, but at the same time, a small blood sample is taken to test for glucose or blood glucose and cholesterol. And we use that opportunity to also use that same finger prick to collect blood for our lymphatic filariasis antigen testing, and to prepare those dry blood spots I talked about, which were tested later on. At the same time, we also integrated a vector sampling and mapping project. So in each of our sites, an entomologist who joined the team set traps and collected information which hadn't been done for the better part of 20 years. We don't need to look at this in any detail, but the yellow boxes on the top are the steps workflow, everything from pre-survey community engagement and getting verbal consent through to analysis, and each of the blue boxes were the opportunities and the position, the places where our LF post-validation survey had an integrated aspect. So everything from getting consent and doing the community engagement right through or potentially right through to analysis. It's a dotted line still, but there is a great opportunity there to look at person-specific data across both NCDs and CDs. Quick photo to give you a sense of the setup. So this was the stations that people walk through with steps, and you can see that it's a big activity. There's a lot of people involved, and that we just literally at that station be there. And my colleague, with her back to us, is that we just took the bloods and did all our work up in that little space, which sort of meant that the STEPS program didn't need as many resources, didn't need as many humans in the process. So they saved a little bit of time and money, but also allowed us to sort of seamlessly integrate with something without causing too much disruption. So when we talk about what made the Niue Steps survey work, the Niue Steps LF survey work, I think probably the most important thing was having this fantastic colleague in the Ministry of Health, Griselda, her name is, who showed just amazing leadership and was able to advocate for this concept of integration. Without her and without the ministry in Niue really making all the partners work together, it wouldn't have been as successful as it was. So my first, I guess, takeaway message for other people thinking about doing an integrated approach for LF surveillance in the Pacific, at least, is that we really need Ministry of Health buy-in to drive it. It can't just be the externally driven programs. Secondly, in the Pacific, NTDs, or maybe NTDs everywhere, well, it's in the title, isn't it? Neglected, and perhaps don't have the same attention that other diseases have. And in the Pacific at the moment, the whole NCD epidemic is really dominating. If it hasn't got an NCD angle, it's really not getting much airtime in discussions. So being a neglected tropical disease program, we clearly don't have a lot of money to spare or resources to throw at these issues. So by partnering with something which is important to the government, but also the public, we're able to get some carriage. Just logistically, there's a lot of, there can be stress when we're doing field surveys. And the fact that our program had a very clear and specific role, and we fitted into the workflow of the steps survey logistics without any fuss, meant that we were a welcome guest. And finally, a recognition that through integration, both money can be saved, but more importantly, in these very small island states where there is such small workforce numbers. I mean, in Niue, I think it's 2.5 people work in public health in the whole country. Just a recognition that through integration, there's cost, but also labor savings opportunities really was a driver. So when we look at the results, and we won't go into them here, but our survey did find one case, so definitely Niue has maintained its elimination status, but through the dry blood spot analysis, we found a number of antibodies too, which have been followed up. And while this isn't published yet, just a little snippet of what some of the dry blood spot analysis results will look like. We also did a costing study, and this is probably the bit of work that's really getting most attention in Niue and elsewhere. And through that study, we found that the integrated approach for our program saved us about 43% in cost, so almost halving the cost to deliver a post-validation survey in a remote country. But really critically, it almost halved the labor costs required of the Ministry of Health. And that was a sales point. This article's just been published this week, actually, came out. So if people are interested in looking at our costing study, take a photo of or scan the QR code there, and it'll take you directly to it. So really key points are integration requires a whole bunch of factors. Key among those is strong leadership from within the ministry. It won't happen without that, especially in places like the Pacific, where lots of the service deliverers are externals who come in for a short period of time. That's definitely needed. Integration clearly saves money and saves labor, and that's one of the biggest sales points for ministries. And the Niue is doing a great job and is continued to maintain its elimination status, despite the countries around them struggling to do so. Finally, a whole bunch of partners came together to make this happen. Central to those was Glide through the Falcon Award, but other partners including the WHO PAC-MOSI program, the Australian National Centre for Immunisation Research, and the Ministry of Health, and of course our team at UQ. Thanks, Nafal.
Thank you. Thank you very much, Dr. Adam and also Dr. Ajib. Dr. Ajib for the two very comprehensive and insightful presentations. We will now move into the moderated discussion and Q&A session. Let me quickly scan the chat box. Okay. So unfortunately, we still don't have any question in the chat box. So while we wait for the questions from the participants, perhaps I can start asking both speakers for a brief reflection. Because we started with Dr. Ajib, now I will start with you, Dr. Adam. So for Dr. Adam, how does integration contribute to resilience against recrudescence or reestablishment of disease from your perspective?
Yeah, good question. So integration, I mean, I guess there's lots of ways to answer that question. I mean, our experience in the Pacific, where we saw 8 countries, have met the elimination targets. None of those countries have been able to do post-validation surveillance without external support. That's unfortunately the reality in this context, and it's not without trying, it's not without effort, but just the priorities, the focus moves elsewhere. So through integration, through taking an integrated approach, we have another avenue, and by integrating with something as big and as a juggernaut like the STEP survey, it becomes low-hanging fruit for a ministry to say, yes, let's do this. So I think just purely through the fact that integration allows us to do some surveillance work and to detect things early, we will prevent recrudescence.
Yeah.
Yeah. So I think other examples of this, other countries of adopting the Niue model. So Wallis and Fortuna are doing this at the end of this year, integrating with their STEP survey. Palau is looking to integrate with migrant screening. Cook Islands is integrating at the moment. So everybody is very inspired by the work from Niue, and with thanks to the Glide team for making that happen.
Okay, thank you so much, Dr. Adam. Now we have several questions pop up in the chat room. But before that, maybe I will just jump to Dr. Ajib now. So I understand you already highlight about this question in your presentation, but could you please re-elaborate or re-emphasize how can program reviews in Indonesia be strategically positioned as advocacy tools? Over to you.
Okay, thank you, Nova, for the question. It's very strategic, I might say. So I think program reviews have become powerful advocacy tools when they move beyond technical findings or operational findings and start explaining why the bottlenecks matter politically, economically, and even systematically. And the integrated review that we have conducted was not only about identifying program weaknesses, but it helped demonstrate that the remaining challenges are linked to broader issues like governance and health system issues like decentralization, fragmented financing, gaps in the workforce, and the coordination among the ministries. And this I believe will change the conversation. So instead of saying, oh, the leprosy program has a problem or LF program needs more support, we can demonstrate multiple diseases are affected by the same structural barriers. So I think that will capture the attention of the stakeholders in any country if possible. And program reviews can also, I believe, generate evidence that is highly useful for multisectoral advocacy because they also provide concrete local level examples, and policymakers often respond more strongly to operational realities than to national averages or data in general. And one important thing is that reviews will be more influential when they are aligned with the broader reform windows. So timing is important, such as national development planning cycles or health system transformation agendas, or any a period of discussions on financing sustainability. I think pitching or ideas or the review findings during these periods are also critical to be heard by the policymakers and also stakeholders. So I think how program views become strategic advocacy tools is that when they connect these technical or operational evidences to the systems or systemic issues that policymakers can act upon. So yeah, back over to you, Novel.
Thank you, Dr. Ajib, for the response and also feedback. Now we have a lot of questions in the chat box, and I really apologize to all of you because we only have like 5 minutes remaining time, so we cannot address all of them. So I will just maybe pick up some of them to be responded by our speakers. Maybe I will just continue with Dr. Ajib. So there is a question from Alison Crantle here. The last one, I will just read for you, yeah. Dr. Ajib, thanks so much for sharing the next step for post-skin NTD program review. Very interesting to see how the results have moved on. Can you comment on the process of including NTDs into the national development agenda in Indonesia?
Okay, thank you, Dr. Allison, for the question. So in practice, it has been very challenging to include NTDs into the national development agenda because it requires us to move beyond the health sector. So we had to have our approach to other cross-sectoral ministries like ministries of agriculture, ministries of public works, and so on and so forth. So one important step is, as I mentioned in the slide, is generating evidence that speaks the language of the policymakers and planners. So we had to change the technical findings into the policymakers' languages and how that this will benefit them, and what we need, what the health sector has already provided, and what is missing that can be provided by other ministries. And this we could connect the evidence to the national targets, the longer term national targets, and that would also somehow push them to contribute in the entities elimination agenda, because that would also affect the performance indicators as in their daily work. So we had to include all of those in the discussions towards the development of NTD national level NTD control policy, and this would also be the umbrella for all of the coordinating ministries to sustain the program post-elimination or post-validation programs for surveillance and also for the financing part. So integration into the national development agenda, that will require also formalization. So it helps institutionalize coordination mechanisms and define responsibilities across the sectors and strengthen accountability as well. So yeah, I hope that answers the question. Thank you.
Yes, thank you so much, Dr. Ajib. Now I'm moving to Dr. Adam Craig, still from Dr. Allison. So thank you so much for sharing the integration of LFPVS with STEP survey. Are you expecting this model can be institutionalized in the future, and also can be continued in the future, especially maybe in Niue and other small island countries? Over to you,
Great
Dr. Adam.
question. Thanks, Michael. And great question. So yes, short answer, yes. I think Niue is sold on the concept and we'll be looking to integrate engage us to integrate with blood surveys in their next steps survey. So that's in a few years' time. And as I mentioned, other countries are jumping on board based on the Niue example. So it's obviously striking a chord. There's another question there about what are the major challenges. I think it sort of relates to your question, Alison, in that perhaps structurally one of the major challenges is, while we talk about integration and the great opportunities it offers, some people don't see it that way, and some people maybe the way they think and the way they're funded is very much programmatically, and that integration perhaps is a risk for some. A risk to success, a risk to processes you're aware of. So that's definitely a challenge to consider, and maybe it's about how we frame measurement of success. It's not only about delivering it a program, it's about delivering a program efficiently, and here are the mechanisms to do so. I think second to that, and to answer another question there around did we just survey adults, or did we also look for kids? It's finding that not all programs will work together well. The STEPS program worked quite well, but it didn't include children, so we had to supplement our survey with children, which added another level of complexity, which perhaps if we had have had the opportunity to work with a different sort of program, such as a household health survey, we may have overcome. So getting that right mix, the right diseases, the right opportunities is critical.
Thank you, Dr. Adam, for the answers, and also for helping me identifying the question from the chat box. We have a lot of them. Dr. Ajib, maybe this is the last one for you. This is from Emmanuel. So the question is, as part of these elimination efforts of NTD, of course, and also maybe other communicable disease, do you think of person affected be involved in some elimination activities? And maybe I will just add one more quick question. Did you also have any chance to involve people affected by NTDs during the program review in Indonesia? Over to you.
Thank you, Emmanuel from Liberia. So yes, we did involve people affected with entities, both LF and also leprosy, and also yours during the program review. And we believe that people affected by entities will bring perspectives that maybe the programs and policymakers might overlook, and they understand the barriers to care-seeking efforts, and also the stigma and discrimination that they might feel. Maybe they could share their experiences on the treatment adherence, and whether if they have experienced the disabilities, then about the disability management. And also what's also important is the trust within the communities and also towards the health workers. And during our program review, we observed that this personal experiences, mistrust, and stigma can significantly affect the screening participation, the contact tracing. So basically, the participation rates of each of the activities conducted on a daily basis, and the engagement should be of this community should be enhanced, I believe, into and also integrated into the program review. So yes, it's a critical component of sustainable elimination effort in this case.
Thank you so much, Dr. Ajib, and my apologies for being unable to read all questions in the chat box. I think we now need to conclude our discussion. Thank you very much to both of speakers for sharing such rich and practical experience today. But to conclude this discussion, perhaps I will just invite both speakers to share one short final reflection on one question. So according to you, or from your perspective, what is the single most important lesson that countries or programs should remember when trying to sustain the elimination of NTDs through integration? I will start with Dr. Ajib and then going to Dr. Adam.
I believe political commitment and financing sustainability. So that's two. So I will choose political commitment then.
Okay.
Over to you.
And I'll say ministries, well, health leaders have a role both to manage downward, so manage programs, but also manage up. So if countries can advocate to their donors and their technical partners, such as WHO, that they want integration, they're more likely to get that support.
Okay, so political commitment and further
Advocacy.
support from others. Yep, advocacy. Okay, then thank you again. Thank you very much for your contribution today. I think today's discussion clearly demonstrates that integration is not simply about combining activities for co-delivery. It is ultimately, oh, sorry. Okay, it is ultimately about strengthening the sustainability, improving the resilience, and ensuring that elimination can be maintained over the long term. And we need to remember that elimination is not the finish line. We need to sustain the achievement. On behalf of Glide and iCourse, I would like to thank all participants for joining us today and contributing to this important discussion. Now, I think I will now hand over the session back to Farsa for the closing remarks. Farsa, over to you.
All right. Thank you so much to Naufal for moderating this session and our speakers, Dr. Ngozi Arundu, Dr. Adam Craig, and Dr. Ajib Diptianusa, for presenting at our Knowledge Cafe today. 2026 is an exciting year for iCords. In the next few weeks, iCords will be announcing our African Regional Manager. We will also be launching the request for proposals for the establishment of university chapters in Africa. So thank you to those who filled out the registration forms. You can expect more information to be shared with you in the next coming days. Stay tuned also for the launch of the 2026 iCords Mentorship Program, and details on our next Knowledge Cafes will be coming soon. Stay up to date on future Knowledge Cafes and opportunities by scanning the QR code on the left side of the screen. Thank you all for attending, and please take a moment to fill out the Zoom poll before you leave, or fill out the post-event survey once you exit the meeting. Thank you.
Thank you so much.
Thank you.